Thank you very much for your invitation. I'm sorry for this technical delay. We shall speak about a very complex manifestation of diabetic neuropathy, and this is the digestive tract alteration, which is a quite well-known manifestation because at first it was described nearly 100 years ago in Berlin by Boas. But to tell the truth, we have a lot of facts which are not really known by us because of the methods are absolutely diverse. The manifestations are very hardly defined. So this is why we have a lot of things what we should know. But I try to give you some aspects of that, mainly from clinical point of view. First of all, the diversity and the complexity might be explained by the very complex regulation of the gastrointestinal tract. As far as we know, at least 4 levels of this regulation. The first one is the enteric neurons net, which has a sort of autonomic activity. And the next one is the autonomic system with the sympathetic and parasympathetic system. The third one is the central neuronal system. And the fourth one is the net of the Cajal cells. The Cajal cells were discovered a few years ago, and these are responsible for regulation of the enteric nerve system. And the enteric neurons and the Cajal cells are very sensitive to glucose. So it could be one explanation why the digestive tract is so much altered and involved in diabetic neuropathy and in diabetes. And possibly the fifth level is the enteric microbiota. We know that there is a lot of substantial change of microbiota in diabetes. And this is why we have a lot of tasks when we want to treat our diabetic patient. On the other hand, the manifestations can be also very diverse. There could be hypermotility and hypomotility, or hyposensitivity and hypersensitivity in the digestive tract in diabetic neuropathy. And the sensory pathways are altered and involved, and the reflex controls in the digestive tract by diabetic neuropathy. And the final manifestation depends on whether the function which is involved is an excitatory or inhibitory function, because of course, if an excitatory function is altered by neuropathy, then the final result is an inhibition. For example, the parasympathetic function in general is an excitatory function, and if it is altered by diabetic neuropathy, then the final result is an inhibition of the motility of our patients. The next problem is that a striking high number of factors are responsible for the affected digestive function in diabetes. As you can see, the current hyper and hypoglycemia both can alter the digestive motility, or the high or low insulin level, even the current insulin levels can influence the motility. There could be electrolyte disturbances which can also alter the motility, for example, hypokalemia. Of course, the long-standing diabetic exposure itself is a very important pathogenetic factor. All manifestations of neuropathy are involved in this problem. There are some visceral wall microangiopathies, which are also well-known manifestations of the digestive tract. There could be an abnormal GI peptide regulation, and there are a lot of medications which can also alter the motility. All we know, for example, the GLP-1 agonists can do that. If we speak about the diagnostics, on one hand, it's very important to mention that the organic problems should be excluded at first by gastroscopy or colonoscopy in a patient, but the diabetic manifestations are functional ones mainly. So this is why manometry, for example, is applied when the pressure is measured inside the digestive tract, or the golden standard is the gastric emptying scintigraphy now for the visualization of the gastric motility. And there are some breath tests which are also applied So these functional tests are the most important ones. And now I got to one question which should be asked from the audience, as far as I know. Should I ask the question?
Will be on the right side of the live screen, and we kindly ask you to give an answer for the question. Just your opinion, what you think. There are no necessarily wrong answers, and we will let the participants answer a bit, and I will get back to you with the results from the audience. So right now, hypertension has the almost 67% hypertension.
It's great. Okay. So I continue.
Please.
Okay. We should speak shortly about the organs separately, and the first one is the esophagus. What we know is that up to 50% of diabetic patients might have some disorder, mainly a sort of impaired emptying. And it's also interesting that the symptom frequency is absolutely diverse, because the prevalence is between 2 to 75%. What is involved is mainly the esophageal body on one hand. There are some abnormalities during manometry, for example, in diabetic patients. And on the other hand, there is a decreased tone of the lower esophageal sphincter, and the final result is reflux. And this is the reason why heartburn is one of the most prevalent symptoms in diabetic patients who have some abnormality in the digestive tract. And it is also well known, and I made a short literature research, and this is still true, that there is no real close association between autonomic neuropathy and the esophageal abnormality. This is our experience when we tested type 1 diabetic patients with very long-standing disease. And you can see that if we follow the esophageal content by scintigraphy in these patients with longer than 20 years of type 1 diabetes, you can see that the emptying of the labeled water by the 15th second in our patients is much lower than the normal range in healthy people. So one of the leading problems in long-standing type 1 diabetes is the slower esophageal emptying. The next organ is the stomach, and the stomach has a historic role in the digestive complication. This is the most well-known manifestation of digestive diseases in diabetes. The prevalence is quite high, and there could be very severe symptoms in most of the cases, which are really characteristic, like postprandial fullness, early satiety. The patients have nausea, vomiting, bloating, and abdominal pain. So the quality of life is impaired very much. And in the background, there is a close relationship with the vagal dysfunction, so the parasympathetic dysfunction. And there could be also an hypo and hypersensitivity at the level of the stomach in diabetic patients and in diabetic neuropathy. And the relationship between the severity of the symptoms and the proven gastric abnormality is weak. And the emptying is slower in most of the cases, in long-standing disease mainly, and it depends on food consistency. So it's more severe in case of hard food, and it can be rapid in some cases, mainly short-term type 2 diabetes. And this is also associated with higher glucose when the gastric emptying is increased. The main problems is a lack of accommodation of the upper part of the stomach. When the food comes from the esophagus, the accommodation of the stomach is impaired. There could be arrhythmias if we follow this by electrogastrogram, and there could be very characteristic abnormalities which can be found, for example, in manometry. And these are real characteristics of vagal neuropathy. So by manometry, we can make the diagnosis quite easily. And what is a very characteristic abnormality is the antropyloroduodenal incoordination. So incoordination of that upper gastrointestinal organs. What we have found in long-standing diabetes is that the half time of emptying by gastric scintigraphy is much longer in type 1 diabetic patients, as you can see, almost 3 times longer than in controls. And if we try to find correlations between gastric emptying and autonomic neuropathy, then you can see that there is a close relationship between this emptying abnormality and the autonomic neuropathy score on the left panel. And on the right panel, you can see one of the most sensitive parasympathetic tests, which is also in a very, very serious relationship with the half-time of gastric emptying, which means that if there is an abnormality at the level of the heart rate response to deep breathing, then the gastric emptying is more abnormal in diabetic patients. If you look at the frequency, we can find that almost in unselected type 1 diabetic patients, almost 1/3 of them had a slower gastric emptying, and only 2% of them had a rapid gastric emptying. And if we look at it at unselected type 2 diabetic patients, we can find the same, that around 1/3 of them has a slower gastric emptying, and none of them had increased or rapid gastric emptying. And we got to the second question. This is about what is the most characteristic manifestation of gastric dysfunction in diabetes, and you can find 4 options for answer.
Yeah, we are inviting the participants to answer with the correct answer, the one that they think it's correct, and or they know that it's correct, and we are going to leave them about 20 seconds. So we will have a statistic, and I will get back to you.
Okay. Okay, then I get further. Okay, and now I would like to speak shortly about the GI symptoms. There are some upper gastrointestinal symptoms, as I mentioned: nausea, vomiting, bloating, abdominal distension, early satiety. This is very characteristic. There could be some complaints with the reflux disease, and there could be diarrhea and constipation as well. So this is a very interesting manifestation at the level of the bowels, when diarrhea and constipation both can happen in diabetes. And you can also see at this figure that there are some anti-diabetic treatments which can also induce these kinds of symptoms, like, for example, bloating by the alpha-glucosidase inhibitors, or early satiety, postprandial fullness by GLP-1 receptor agonists, or as all we know that abdominal pain or diarrhea can happen with metformin treatment. So not only diabetes, not only the several factors, but the anti-diabetic treatment can induce digestive symptoms, as you can see here. It's also interesting that there is no real correlation between the symptoms, between the severity of symptoms and the emptying of the organs. So for example, in our population, we haven't found an association between the esophageal, gastric, or gallbladder scintigraphic objective emptying disorders and the severity of the symptoms what the patients feel. For example, here you can see that the autonomic neuropathy is in a correlation with the symptoms, but not the digestive disorder itself. So it means that in the genesis of the symptoms of the digestive tract in diabetes is more induced by the autonomic neuropathy than the objective motility disorders. So this is why we can say that there is a paradox of neuropathy in the pathogenesis of digestive symptoms, because on one hand, there could be an absence of symptoms in patients with really severe disorder, which reflect an afferent nerve defect. On the other hand, there could be a visceral hypersensitivity in patients who have serious symptoms and there are no motility alterations. So this kind of paradox is present at the level of the digestive tract. As I mentioned, these complications alter the quality of life, but alter the glucose homeostasis as well. Because if you look at this situation, if a patient has a delayed gastric emptying and the patient receives an insulin injection, then there is a delayed gastric emptying, and this is why the absorption of the carbohydrates is altered, is slower. So this is why a hypoglycemia can happen in this patient. And later on, when the delayed emptying is done, then there is a hyperglycemia. So hypo and hyperglycemia both can happen in these patients. For example, we have a diabetic patient who had a very, very slow gastric emptying because he had diabetes, chronic pancreatitis, and chronic alcohol intake. And as you can see, his emptying was 497 minutes, which is very, very long, much longer than the normal emptying. And if you look at his CGM values, then you can realize that at every morning after breakfast and at every evening after supper, this patient had hypoglycemia because the gastric emptying was delayed, and this patient lost his consciousness. So he had so severe gastric abnormality due to the neuropathy. Just a moment. If you look at the risk factors of altered gastric emptying, we can find it in an excellent Norwegian study, and you can see that the lower BMI, the higher HbA1c, the presence of retinopathy, and the history of food ulcer, these are all significant predictors of impaired gastric emptying. So if you have a patient with these parameters, then you should consider to look after the gastric emptying of your patients. Very shortly about the gallbladder. The gallstone disease is very frequent in diabetes. There is a sort of increased volume of the gallbladder, and this whole motility abnormality looks like an atropine pre-treatment. So it means it looks like a vagal abnormality. And the gallstone and the hypomotility together at the level of the gallbladder might be associated with symptoms. What you can see here is that when we followed the scintigraphic emptying of gallbladder in type 1 diabetics with very long disease duration, then the ejection fraction, so the ejection of the gallbladder was much, much lower than the healthy controls. It was 1/3 of them. So there is a lazy gallbladder in these patients. And when we looked after the correlations between this lazy gallbladder function and the presence of autonomic neuropathy, we have found very strict correlations. It means that the parasympathetic abnormality is responsible for the slower gallbladder emptying. You can see that the presence of gallstone disease in unselected type 2 diabetic patients is almost 18%, compared to controls with 6%. So this is why the prevalence of gallstone disease is very high. Very shortly about the small and large bowels. As I mentioned, constipation, diarrhea, and incontinence all can be found in these patients. There is an incoordination at the level of the bowels. There is also an increased intestinal fluid secretion, which is an explanation for the diarrhea. There could be a decreased ganglion size if you look at the histology of these bowels in diabetes, and there could be an enteric neuronal abnormality. So the autonomic enteric neuronal net is impaired, for example, the myenteric and Auerbach plexuses. And what is also a characteristic abnormality is the anal sphincter abnormalities, for example, the external anal sphincter abnormality, and there is an anorectal incoordination, which is the explanation of the constipation and the incontinence in these patients. Also, a Scandinavian trial confirmed that there is a relationship between autonomic neuropathy and the sensitivity of the bowel. When they had the stimulus at the level of the rectum, they have found it. They have also found an abnormality between a correlation between autonomic neuropathy and physical well-being. And they also have a very close relationship between physical well-being and bowel sensitivity. So the sensitivity, not only the motility abnormality, is also an important manifestation in the digestive tract. Just look at this slide, which is about the gut microbiome in patients with diabetic polyneuropathy, with diabetes, and with normal glucose metabolism. You can see it very well that the bar with red, this is the bacteroidetes, this is the smallest amount in the case of diabetic polyneuropathy. It's more in the presence of diabetes, and in healthy people, it's much more. So we don't know the real consequences of these differences of the bacterial strains in the gut microbiome. But later on, I'm sure that we will hear very much about this because, for example, diabetic neuropathy can alter this. I just mentioned that we applied the GLP-1 receptor agonists, which act on the gastrointestinal tract. That's very interesting in this study, in this Japanese study, that the GLP-1 agonist increases the transit of these patients at the level of the stomach only when there is no neuropathy. So the third panel, the lowest panel, shows you that in patients without neuropathy, the gastric emptying became longer after liraglutide treatment. But the second panel shows that if a patient has a neuropathy, that there is no substantial increase in the gastric emptying. So it means that the GLP-1 agonist has a selective effect on the gastric emptying, and it delays it only when there is no neuropathy. It was also proven by Professor Softeland that the exocrine pancreatic function is also altered in diabetes, even without previous pancreatitis. You can see here, for example, unselected type 1 and type 2 diabetic patients, and you can see that the exocrine pancreas function is lower when the diabetes duration is longer. Very shortly about the treatment options, the optimal glycemic control, of course, is very important. The diet also, if someone has a delayed gastric emptying, then small meals required 6 to 8 times a day and a low fiber content. The prokinetic drugs are applied, but these cannot be given continuously. So only we should advise the patient to get it as a sequence, because long-standing treatment with metoclopramide or domperidone, there could be some central neuronal abnormalities because these act on the dopamine 2 receptors. And there is the etoprid, which is a later development, and it could be, it might have not so many abnormalities at the level of the central neuronal tract. We shall see this. The pathogenetic oriented treatment is very important. So alpha lipoic acid and benfotiamine should be given in case of proven neuropathy and digestive problems. And of course, there could be some symptomatic treatments to diarrhea. And we should also think over the pancreatic enzyme supplementation in some cases with diarrhea, or giving antibiotics or probiotics. Thank you very much for your attention.